So, I was when I talked to Peter about this talk. I wanted to make sure that I am speaking to your needs as a group, and I know the group has different. Um, levels of proficiency with POCUS. So I'm hoping that we can do some general overview for those of whom where this is actually very new, and then and build on that. So talk about additional information you can hope to get with POCUS that might help with additional clinical decision making. So Peter actually shared this with me in terms of these are the high yield sort of required views and pathologies that you're required to have some proficiency with. So I helped this illustration kind of guide the types of views and the pathology that we'll be discussing. So just as a reminder, and hopefully the residents have been getting a good education from our sonographers regarding this. When we're talking about point of care ultrasound, your most high yield views are going to be your parasternal long axis and short axis, your apical views and subcostal. And certainly in patients who are postoperative, even though subcostal is not, preferable in terms of getting all of your echo images from there, there are ways in which you can optimize your subcostal views to acquire everything if the chest is bandaged up. That being said, your parasternal long axis, just as a reminder, the probe marker is going to be at 11 o'clock. And so here you're going to see the RV anteriorly. You're going to get the aortic valve in long axis, the LV with the anterous septum and the infralateral walls and the left atrium. If you shift your probe to 2 o'clock, then you get your parasternal short axis. And depending on your angle, you can get your apical views, you can get your mid views, or you can get your aortic valve views. But this is going to give you the LV in short axis, and your RV is going to be over here. Now, if you move your probe to the apical side, so this is going to be your fifth intercostal space laterally, and you go to about 3 o'clock, between 2 and 3 o'clock, you're going to get your apical views here. So what you have is your LV, your mitral valve, your left atrium, and your RV over here, your tricuspid valve, and your right atrium. Peter, it looks like there's some people waiting in the lobby, and I'm not sure if there's.
I've been admitting him. Don't worry. I've been
Oh,
admitting
okay. I keep getting like a notification. Just want to make sure. Okay, great. And then your subcostal views. So now you're going to go below the xiphoid process, and if you're angulating it to 3 o'clock, then you get your subcostal views. This is your liver over here. You may see ascites over here, so it's very important that you see an echogenic space or echogenic structure to delineate where your pericardium starts. Then your RV, your tricuspid valve, your right atrium, your LV, your mitral valve, and your left atrium. So we're going to use kind of these basic views throughout the rest of the talk. Now, let's just start with a case. So we have a 56-year-old woman with a history of heart failure, and she's not known to our institution, and she's brought in after a motor vehicle accident. She has a cardiac contusion. She has rib fractures and a splenic laceration, and she gets a splenectomy, and it's post-op day 3, and she all of a sudden becomes hypotensive, tachycardic. She's tachypnic, and she desaturates. So she's 91% on a non-rebreather. She ends up becoming intubated, and now the question is, what happened here? What's going on? And certainly, there's certain things that are going to be in our differential, right? And any of these postoperative patients who've been hospitalized, you worry about PE. She has a history of heart failure. We don't know what her history is. So could this be cardiogenic shock? Could the stressor have been too much and it tipped her into cardiogenic shock? She's had a contusion, and over many days, the inflammatory process that results from that can result in an effusion. Could she have tamponade, or could she have a bleed? And certainly, echo can help us answer some of these questions. So, what I'm hoping to go through here is, your LV systolic assessment, and how Doppler echo can help you get further information other than your visual assessment of LV ejection fraction. So by giving you calculations for preload and cardiac output, and how we actually assess pericardial tamponade and the RV.